Welcome to Decoding CTO, case 20. So I'm Dr. Sharath, Interventional Cardiologist from Medicover Hospitals. So this is a case of Ostial CTO. My patient is a 60-year-old male, had a hypertension and diabetes, recovered from COVID, came with an acute coronary syndrome with non-LUMEN, drop positive. His ECG showed ST depressions in inferior leads and echo showed RWMA and RCA territory in the index episode. So this was the angiogram done. You can see Ostial LAD total occlusion, and there is a diagonal which is filling from retrograde, possibly from OM collaterals. Yeah, so this again left system, so in different views. And this is a right system, so there is near total occlusion of mid RCA, which is the culprit vessel for acute inferior LMI. You can also see the LAD filling from right coronary artery, mainly from epicardial collateral. You can see this is what is filling right left-handed descending artery. So in the index episode, primary angioplasty with stent to mid RCA was done, and subsequently patient was discharged in a stable condition and came back for LAD stenting. During index episode, index intervention, so LAD wiring was attempted, but you can see here, so wire went subintimally, and it was withheld. Yeah, so this is the anatomy of this patient. You can see there is a stent in mid RCA, which is done during index episode, and this is the LAD CTO. It's a long segment CTO. Looks straight, but this part of CTO segment is not clearly visible in fluoroscopy. I would rather say it's an ambiguous course of the vessel. And there are a couple of diagonals you can see which are filling from OMs, but their joining LAD is not visible in angiogram. And this LAD is also receiving collaterals from PDA, from RCA, and there are good collaterals, septal collaterals. And this is another epicardial collateral from mid RCA which is filling LAD. Coming to the CTO, so you can see the entry point is, but there is some entry point, but there are a couple of branches around which confuses our wiring during antegrade wiring. And length is long, and most likely there is no angulation. We don't know, there could be angulation, we know only during the course of the procedure. And there was no calcium visible. See, overall, and it's a reattempt, so overall we can say JCTO of 3 with good interventional septal collaterals, also one interventional epicardial collateral. So the plan for this case is antegrade wiring. So to understand what are the problems in antegrade wiring without IVUS confirmation of wiring into proximal cap. So you see here, so if you wire without IVUS, and if the wire went subintimally from beginning, so what might happen is we can push this block onto LCX, and LCX can get occluded, which may lead to an untable catastrophe. And if you go direct retrograde without antegrade preparation by IVUS-guided antegrade wiring, what can happen? So you see here, our retrograde wire is here already, and we are trying to cross lesion, and if you come out in this area, that is in LMCA, which is nothing but a kind of extended reverse cart, or the wire entering into LMCA here. In such situations, when you dilate with the balloon after externalization, you will end up in closing LCX. So this is one catastrophe which can happen on table in these patients with Ostial LED CTO, and which is very dangerous for patients. So that's why wiring strategy has to be cautiously planned in such patients. So always do an antegrade IVUS guided cap entry first, and if it goes from true to true, yes, we can complete antegrade complete procedure. But if it is not going true to true, or if you're not sure of the course of the vessel, you can always go retrograde and then do reverse cut here, because already we are sure that our antegrade wire entry is clear. So this works as a antegrade preparation for reverse cut here to bring back your retrograde wire into true lumen in this portion. So it shouldn't come here. Yeah. So that's how we can complete the procedure. So in brief, so we do IVUS guided entry, and then if it doesn't progress, then we'll take a retrograde. So this is a dual injection. You can see long segment LED occlusion, and which is filling well from the collaterals. From RCA, you can see these are the good septal collaterals which are filling RCA. So what we went ahead with IVUS guided entry. This is the slipstream technique. So we identified LED fast. I'll show you where the LED is. You can see this is the IVUS here, and you can see this is the IVUS. So here what happened, your EEM is not clear here. So you can see here EEM is very clear on this part, that is from 7 to 2 o'clock, and in this area it is EEM is not visible. So that is the area where you will see LED. Yeah, you can see here. So there is an entry, clear entry into LED. So and next comes, this is LMCA. So that's how we can identify a LED or any side branch in IVUS. Then go with the wiring. So we used a GAIA 2 wire initially. You can send CORSAIR over the same wire on which IVUS catheter is. That is the reason we kept IVUS deep into LCX. So we took a GAIA wire. You can see here that GAIA wire is actually, I'll show you the cords. You can see here, this is the wire. It was subintimal. So you have LED here, LED entry is here, but the wire is coming from here. So you can see it is clearly subintimal, and it is from LMCA. So had I continued with this, I would have ended up in scenario 1, which I already explained. So we escalated wire to Harnett for better control, and now you can see my Harnett wire, yes, so is coming from or entering LED. You can see this is the Harnett wire, so which is clearly entering through the proximal LED. That's a clear entry point which is visible in IVUS. Unlike GAIA, which went from here, so Harnett went just into the proximal cap in desired course. So then we have to remove IVUS catheter in slipstream technique. This is very, very important, needs to pay attention. So what we have to do is, you just pull the wire back. Once the wire is pulled back, now the IVUS catheter is out of your wire. So what we can do is, you can just pull the IVUS catheter back. You can see here, as I am pushing, as I am pulling IVUS catheter back without disturbing my wire. So if you disturb this wire, so whatever you achieved, that IVUS guided entry, you are going to pull the wire back, and you have to start rewiring again. So that is very, very important. And once IVUS catheter is back, you can remove CORSAIR catheter with trapper balloon in proximal guide, and then exchange to CORSAIR. So this is the CORSAIR. I have chosen CORSAIR because it gives you good trackability and pushability, which is very much needed in this patient. So you push the CORSAIR into the proximal LID and you consolidate your position in proximal LID, which you have already gained through IVUS-guided entry. Otherwise, if this comes back, you will end up in redoing whole thing again. So once CORSAIR is into the LID, you always de-escalate. This is a harnett wire. You have to de-escalate harnett wire back to GAIA. So never continue your procedure with harnett because that's a stiff wire. You can't really direct it. So yeah, we took a GAIA, but the problem here is we are not able to understand the codes of LID. You can see how distant the wire tip is from diagonal in two views. So that says there is a codes ambiguity. So at this juncture, it is impossible to continue antegrade in this patient. So we went retrograde, you can see here. So we took a guideliner preemptively as we need more support for retrograde microcatheter push into LID. So this is a retrograde microcatheter which is CARAVEL 150. You can see there are good septals. So we tried 3 septals. First septal I failed, 2 septals, and third septal we could cross successfully. You can see here. So this is a SION wire, so which is going to the septal and which nicely crossed the septal. So once we crossed the septal, we advanced wire into the diagonal in LID. You can see here. And then we advanced CARAVEL into LID. So once CARAVEL is in LID, so we changed wire to fielder XTR to cross the LID. And this part of LID course is not clear. That was one concern while wiring. So we took a fielder XTR. So which we advanced, without much difficulty. It went through a channel there. So it appeared as if it is going through a channel. So fielder XTR, as fielder XTR got advanced without much difficulty, so we advanced CARAVEL, and we thought of injecting contrast and see whether both diagonals are filling from here or not. So we injected, so you can see all the contrast went into subintima and we created a subintimal hematoma, which no C2 operator would want in the middle of such a difficult procedure. So once we created a subintimal hematoma, all your next steps becomes more complicated, and we have to pay more attention on not closing LMCA and LCX in such intervention. So what we did, we did advance retrograde wire. It's a GAIA 3 wire using antegrade wire as a marker, and you can see both the wires are actually hugging in almost 90 degrees view, which says both are within the vessel architecture and also quite close. At this stage, I checked retrograde wire position through antegrade IVUS catheter. You can see here. So this is the wire, and this is the LMCA, and the wire is exactly in the LMCA subintima. So this is the second scenario which I explained in the beginning, which would end up in a catastrophic LCX occlusion. So at this stage, what we decided to go ahead with reverse cart in proximal LID. So you can see this is a 3 mm balloon. So and then we went ahead with the reverse cart initially with the GAIA 2 and GAIA 3 wire. Subsequently, I used a harnett wire. As we create a big subintimal space, the directability of wire will come down in such scenarios. So it's always better to use a stiffer wire with a better curve to enter into antegrade space which is created. So you can see this is Ostial LID. So where we re-entered and then came back to diagonal into the guide. You can see now my retrograde wire is in the guide. So then you have to confirm your retrograde wire entry into LMCA with IVUS. We shouldn't go without confirming its position. You can see here, so this is where LAD comes, and you can see the two wires which are coming from LAD. You can also see the subintimal hematoma in LMCA. So now both retrograde wire is coming from LAD, and also this retrograde wire is sitting in guide. You can see 3 wire shadows within the guide, which confirms your wire is within the guide. So now we externalized, and post externalization we dilated LAD with a 2 mm balloon, 2.5 balloon. So after dilatation, we took a WMN catheter. Since stunting here mostly has to be extended beyond this septal branch, so we had to wire main LAD with a WMN catheter over externalized wire. You can see here, after confirming IVUS in IVUS position of LAD. So you can see this is IVUS after pre-dilation. So IVUS is in true lumen, and then here you can see this is the septal from which this is a retrograde wire, and you can also see this is a diagonal, second diagonal, which is coming from the true lumen. And you can see from here where I created a subintimal hematoma, actually my microcatheter went subintimal. You can see this is a compressed true lumen, and this is a false lumen which I created. So you can as well see this is the compressed true lumen in the proximal LAD, and you can see here this is in LMCA. This is all subintimal hematoma which is created by retrograde wires in LMCA. So once we notice this, we have to decide on stunting strategy. Whenever you created a subintimal hematoma in LMCA, extend stunt from Ostial LMCA. That is the safest strategy. So otherwise, if you stunt from Ostial LAD, you may end up in significant lesion in LMCA subsequently. So that's what we decided. So we decided to go with a 2-stunt strategy. It's a 2.75 38 mm followed by 3.5 28 mm. So after proximal stunt, we did a pot with a 4.5 balloon, 4.25 or 4.5 balloon based on IVUS sizing, and then this is LCX ostium, which we have to study after IVUS. You can see here, so LCX ostium appear to be slightly stenosed, and we did an IVUS of LCX ostium. So this is the IVUS MLA, that is 2.7 mm square, and this was the IVUS MLA to start with, that is almost 5.8 mm square. So we compromised LCX ostial lumen by more than 60 to 70%. So that's when we decided, part of it is because of intramural hematoma, which is also shifted into the subintimal space of LCX. So that's when we decided to go ahead with the second stunt into LCX with the tap stunting. So we did the tap stunting with 2.75 38 followed by kissing and followed by report. So this is a report with 4.5 by 10. So and this is a final result, so which you can appreciate. So we got a good result of LAD and LMCA bifurcation. So points to take from this case is, approach to Ostial LAD CTO needs special attention to avoid on-table catastrophe. IVUS-guided antegrade cap puncture is essential, which also acts as an antegrade preparation for retrograde. And direct or conventional reverse cart can be used. No extended reverse cart in Ostial LAD or Ostial LCX lesion. Stunting strategy needs to be dynamic and decide based on IVUS appearance of distal LMCA after reverse cart, after externalization. Intramural hematoma in left main in IVUS, stunting from left main ostium is a safer strategy. Always reassess Ostial LCX in intramural hematoma scenarios. after LMCA to LED stenting. Thank you. So you can subscribe our channel into which we regularly post decoding CTO and decoding complex PCI cases.